Thank you. Thank you. And thanks for inviting me to speak here. I realize that I do give talks at various platforms, but neurosurgery and DBS, I don't think I've ever given it to non-technical audience. So please excuse me if I use quite a lot of technical language. I tried to simplify the talk a little bit while I was sitting at the back. I'm Himanshu, and I started my kind of journey into research by first being a clinician. I became very interested in OCD when I worked with Dr. Drummond's unit at Springfield. I saw both CBT and exposure-based CBT and medication work really, really well. And I was quite intrigued by the patients who do not get better. What happens to them? So that started my journey on deep brain stimulation, neuromodulation, etc. And so just this is my disclosure slide. These are the two places I work at present. So I work half of my week I spend at Queen Square, where I try to do neuropsychiatry for OCD and some neuroscience-based research one day a week in the Department of Functional Neurosurgery. I'm the one of the two neuropsychiatrists there. Amongst all the neurologists and neurosurgeons, and then rest of the time I spend at Priory Hospital, which runs a highly specialist unit, a sister unit to Springfield Hospital, commissioned by NHS England, where we treat OCD as inpatient. So it's a very small unit. We take 2 or 3 patients from NHS England. Okay. Okay. And so to start with, I'm going to put it in context. So these are NICE guidelines, which have been there, one of the first major mental illness guidelines from NICE. They have been around since 2005. There hasn't been a major revision, which probably speaks volumes about the robustness of the treatment we have got, but also kind of on the downside, we don't have the new developments reflected in the guidelines. So these NICE guidelines loosely translate into this step care model for OCD, which we use in NHS, which Dr. Pampeloni talked about. And there are various steps. Most of the highly specialist services are concentrated on step 5, step 6. So both Springfield, SLAM services, Hertfordshire services, and the service I run, they are at levels tier 6. Now, what do we do in these services? These are the two treatment which have the highest evidence at present clinically. So exposure-based CBT, SSRI, there have been, over the last 50 years, there have been numerous trials demonstrated their efficacy over and over again, making OCD one of the most responsive to treatment illness, and not only medication. We see similar response with exposure-based CBT as well. So at tier 6 and tier 5 services, we try to combine them both, which has the highest form of evidence. So we combine ERP as an inpatient, or residential settings, or intensive home-based settings with the SRI, and that has the highest response rates. So most of the patients who attempt this treatment would benefit from it. Now, it is important to kind of think about OCD in that way, because it's a kind of quite a common mental illness, undertreated, underdiagnosed, mistreated, misdiagnosed throughout the world, and it's one of the most disabling mental illness, as we have heard from other speakers earlier on. And the global burden of OCD is more or less uniform around the world. The red regions is where WHO has estimated it is more, affecting more the orange, and then the yellow is the least one. But if we look at the actual numbers, there isn't a lot of difference between these shades. So OCD is universally considered as a quite disabling condition. It would affect every aspect of the life, the family life, the relationship, education. It starts in the formative years of life, most of the times, employment, intimate relationships. If it is not treated, and considering the fact it's a treatable mental illness, if we get the treatment right, if it is not treated, people then either live on their own, or they are cared for full time in more kind of difficult presentations. And there is a direct loss of productivity. One charity estimated in 2013 that the direct loss of productivity is around 65,000. It's not every 3 years. This is not counting everything else that goes along with it. And there is a follow-up paper which Nick mentioned earlier on, which kind of estimated the effect is 5 to 10 billion, the effect, the cost of OCD in UK. Now, Usually, what do we do when we get patients who need combination of these treatments? So we'll treat them, start with medication, which is usually serotonin reuptake inhibitors. They are pretty effective in most cases, combined with exposure-based CBT. So the top line is about medication, the bottom line is about exposure-based CBT. We are combining them both in our highly specialist services. And this is the usual kind of response we'll expect in majority of the patients, not in all, majority of the patients. So we'll have all these modules added onto patient treatment. However, there are big gaps. And the first gap is at the beginning, when the patient presents to us, usually in a crisis, and we don't have any short-acting OCD treatment. And we can use short-acting anti-anxiety medication, but their use creates another set of problems. So we have to wait for these medication to work. Exposure is not going to work straight away as well, and it's hard work. If someone is in crisis, it's not going to be effective straight away. Its patient probably is not going to be able to utilize the techniques we are offering. So we have a kind of severe lack, a black hole of rapid-acting interventions, which I'm excited that Orchard is funding a couple of projects which probably might change this. But at present, we don't have anything concrete. There are many techniques like RTMS, TDCS, GABA, gluta modulator, which are on the horizon, which might change this. But at present, we don't have anything which we can use in the first instance. Then, towards the end of this chain, most patients respond in some way, but there is a very clinically distinct group of patients. The estimates would vary depending on which research paper or estimate we are reading. But in my own clinical experience, there is like 1 in 10, roughly 10%, are truly treatment resistant. Whatever we deliver means in terms of pharmacological, psychological therapy, they do not their symptoms do not seem to respond. And that is the group I became very interested in. So what should happen? Where should we go with the treatment? So treatment refractory OCD means if you look at it, the costs, as I touched upon earlier, they are massive. Untreated OCD cost would add up every year in terms of direct, indirect loss of earning, etc., and the cost by NHS and the cost of caring, etc. There is also this case that post-successful treatment, most patients we will expect them to return to pre-morbid levels of functioning. So that means that they can, in theory, become productive members of society. So there are strong clinical economic arguments for the patient, for families, even for the organizations and government to develop new treatments, which there are several on horizon, but I think the progress probably can be speeded up, or OCD research can be funded more. Now, advanced treatments which we are going to focus on are deep brain stimulation, adaptive deep brain stimulation, which is now emerging. Cingulotomy and capsulotomy are the two surgical techniques which have been around since 1940s, and they are still being used. They're pretty effective, and at present they are used in a modern neurosurgical framework. And then there are future approaches which might negate the kind of need for us to have invasive brain procedures like functional ultrasound. Now, step K model, if we think about how these interventions would fit, I would argue that NICE has 6 steps and probably a 7th step they need to add to the step K model where all these interventions should fit. What happens when step 6 interventions do not work? At present, the only option we have is to repeat step 6. So step 7 is where this TMS, TDCS, DBS, or new emerging treatment or neurosurgical options which are already there can fit in. Now, once we start thinking about these neuromodulatory interventions, we are then forced to think about OCD as a neuroscience kind of neuropsychiatric disorder. And there is kind of quite a lot of literature that has been published in it. I would argue that OCD is one of the most neurobiologically understood mental illness at present. We have the information. We need to develop new treatment for at least 30 years. But there seems to be, means I have one step in one leg in research world and one leg in clinical world, and I see a disconnect between the two. I do not see this rapid kind of translation of research findings into clinical areas to develop new treatments. So that does not seem to be happening. But we do understand that OCD is a prototypical neuropsychiatric disorder. And OCD has been a prototypical disorder for psychiatry for now 100 years, say many things. Be it psychodynamic therapy, be it CBT, be it psychopharmacology. And at present, it is the prototypical neuropsychiatric disorder. That means we understand the neuroscience, and it starts with this paper, Alexander, who outlined these loops inside the brain. These are functional loops. We can't see them on the scan. So he outlined these loops in animal models in 1986 and called them kind of basal ganglia circuits or loops. And he demonstrated that they are parallelly organized, and they are they can be segregated, differentiated in terms of their function, etc. And the research community and medical community were quick to correlate this with what probably is happening in OCD, what we know from existing studies. So very quickly, a model kind of emerged within 10 years. We called that model cortico-striato-thalamo-cortical, CSTC circuit. This is just names of the various stations in the brain. And this circuit has since been refined, developed. And in OCD, we know that it's much more than CST circuit at present. And some of the research we have done has contributed to that as well. But the basic understanding of the circuit is it's kind of three different circuits in one. So first one we call direct circuit, which connects, which you can see in green over the side. If you trace the green lines, that's the direct circuit. Then we have an indirect right circuit, which is connecting different paths, and then a hyperdirect circuit. I'm not going to go into details, but these are the three circuits we try to manipulate with any neuromodulation, be it deep brain stimulation, be it deep TMS. Now, modulatory approaches, they have their advantages. Medication is a form of modulation as well. It's chemical modulation. We started with it first because it was easier to deliver. In 1960s, we did not have the technology to deliver electrical modulation easily. So chemical modulation is what we know as medication at present. It has to be taken through the mouth. It has to go through the bloodstream, and blood has to go everywhere. So it's not precise, but it works. It does cause a lot of side effects, but it goes everywhere. There is no hardware that is needed for chemical modulation. It's inexpensive. It's imprecise but effective, and that's the main kind of route most of the psychiatric treatment has taken since 1960s. Now, electrical modulation, because it requires specialized hardware, specialized training, computing, it's relatively expensive. It does promise precision, as Nick was saying, that precision medicine, we are looking at probably the advent of precision medicine, that it does promise, but it is difficult. And the system at present is not designed to support electrical modulation techniques, although things are changing. Then there is a third way to probably achieve the same thing by doing lesions, which is what we call surgery. And there have been a number of techniques which have been used over time. At present, we use a stereotactic frame, which is then used to deliver very precise lesions in the brain in the area which was mentioned earlier in the talks, ACC, and that seems to be pretty effective. It does involve loss of tissue. So our kind of thinking was in 2012 when I became part of this group, which was thinking about DBS, that electrical modulation is the next frontier. Let's look into it and see if we can make things different. So we looked at all the modulation targets at that time, which were being reported in cases or research throughout the world, and we kind of zeroed into these 7 main targets. I'm not going to go into detailed anatomy, but what we did eventually in order to design our own trial, and by that time in UK we haven't tried any deep brain stimulation by that time. So what we did is picked 2 top targets which have been reported in literature as being effective. And we also made sure that these targets are also probably, that's what we assumed, are lying on different circuits. Remember the 3 circuits I outlined in the diagram before? So we thought that these 2 targets are on different parts or different kind of sub-circuits of the same CSTC network. And we had this idea that in 2012, the group, and I see many people sitting here who were part of this consortium. I was probably the last person to join it. And we had this idea that if we combine two targets, which probably are on different parts of the circuit, maybe we can get a better result from what is being reported. And sorry, this was the first DBS trial, which was reported by Bart Nutan in 1999. That was reported to be effective, 3 patients. And then going back a little bit into the history of deep brain stimulation, it was a serendipitous discovery while trying to treat a Parkinson's patient by this neurosurgeon neurologist, Dr. Alim Benabid. And so they, before trying to do the lesion, they were testing out the effects by doing an electrical lesion, a temporary electrical lesion. And what Dr. Benabid was intrigued about is that these effects are as good as kind of doing ablation, like losing the tissue. So why do we have to do that? Can we develop an electrode to deliver this permanently? And that was the start of the DBS, modern DBS. Now, modern DBS means it has been around. When we look at the history, it has been around since 1950s. But the hardware to support it did not exist. We did not have portable lithium batteries at that time. So the person had to carry the battery or be in this very specialist lab settings. But the interesting thing, when I looked into the old literature, they were trying to target similar areas which we are trying to, which we think are effective at present. So modern DBS, as you can see, this is modern DBS. It does not leave any trace. If once the hair grows on the skull, you would not be able to figure out any bump or any kind of that the DBS hardware is inside. Now, how does it work? There are 2 electrodes which are implanted deep into the brain. So there is a small burr hole, a coin-shaped hole that is made on the top of the skull, and the electrode is pushed through that. So there is this is superficial brain surgery. If you think about it, it's brain surgery. It has a risk of dying. All brain surgeries have risk of dying, 1%. But it's superficial brain surgery because the electrode is implanted without opening the brain. We just open the skull and push the electrode through. The whole procedure is done by using stereotactic frame, which is a very precise technique of guiding these electrodes. The surgeons would spend hours, means the operation itself can last 30 to 90 minutes, but the surgeons would spend hours in trying to find the best trajectory, which is going to not cross any blood vessels, not cross any empty spaces in the brain, and going to support the electrode. So it is also a very precise technique. I think the error of the site we want to target, the error has been reduced now to 0.07 millimeter. So more or less, the electrodes end up in the area we want them to end. Every brain is different, so it's difficult to control that. But the surgeons, at least at UCL, have reduced that error rate to less than 0.07 mm. There are batteries, depending on how many electrodes which are implanted, either in the chest cavity, sometimes they can be on the back or in the abdomen. And these batteries have the programmable unit as well, which can be programmed from an outside wireless controller. Nowadays, we have rechargeable batteries. They can be recharged depending on how much electricity is needed. They can be recharged daily or weekly. And these electrodes at the tip, as you can see here, there would be number of contacts on either side. When we did the study, we had 8 contacts, but now we have 24, up to 24 contacts. Now we have electrodes which can read what is happening at that location, send the information back to us. That is adaptive DBS. But when we did the study, the technology was still quite simple, new. So we had 4 contacts on either side, and they were not able to tell us what is happening in the location. Now, this is the group, and you might recognize many of the faces here. So the main questions we asked at that time, 2012, when we started this trial, does the theory translate into results, clinical results? What are the best targets? Can we combine 2 targets to get even better results? Can we combine 2 targets to get results in terms of other problems we see in OCD, like depression? Can we get a psychiatrist to run the trial? Now it looks like a simple question, but by that time we couldn't find many psychiatrists who are doing research in deep brain stimulation. It was led by neurosurgeons, in some cases neurologists. The problem with that was, although the technology was evolving very fast and the surgery was becoming very precise, it was really difficult to get a long-term follow-up of these patients who have a chronic lifelong illness. So we had snapshots that this works. We did not have a long-term picture. And surgeons and neurologists, because they get discharged after surgery, would not be able to report or provide that. So we wanted a psychiatrist to run the trial, which we did. We got a few, not one, including the person who coordinated, that was me. And so we also had few mechanistic questions. What does it tell us about how OCD works in the brain? Now, interestingly, the trial, this was the design. It was a 15-month long trial compared with 3-month or 4-month trial that we had in literature. By that time, most of the trial was of shorter duration. So it was one of the longest trial. We added cognitive behavioral therapy at the end of it. And we wanted to see if we combine deep brain stimulation with CBT, do we get even better outcomes? If we combine two targets, do we get better outcome? Is one of the target, we picked a ventral capsule, ventral striatum as the top target, and subthalamic nucleus as the second target, which our hope was that it's going to help more with mood as well. We kept every patient. We had 6 patients recruited through the highly specialized services, 3 months on one target, then moving on to 3 months on next, and 3 months on both targets, and then 3 months on both best target plus CBT. So it was quite a long trial, and it was reported in 2019. And all 6 patients had response. All 6 patients which we recruited through the national services had an average of, I think, 24 years of OCD. And Nick talked about one of the patient he is familiar with. That was 24 years of untreated or non-responsive OCD. All 6 had response in this trial. I remember when I was recruiting them and following them every month, every patient I was doing, and I was terrified that the next patient, probably I can't be lucky with all 6. The next patient is not going to respond. Next patient is not going to respond. And interestingly, what we did not report in the paper is because I've worked in the highly specialist services before this. It was not only a control trial for the intervention we are using, it was a control trial for me as well. I was the therapist for 2 of these patients, and I was fully convinced that none of the things we can do in terms of therapy would work for these patients. So I did not have that doubt in my mind. So what I was seeing at that time, luckily I had the front row seat there as the coordinator, what I was seeing I could fully believe in. So this is what we saw. So first month, all the patients, and this is the month line here. First month, regardless of which site we used, the Y-box, their main severity measure dropped. It dropped massively. It dropped to the extent that for one patient, I felt useless because I treated that patient for 2 occasions, 6 months. And I thought, why did I spend 12 months with this patient when we can do this in this situation? Now, this drop was maintained. And as you can see, in the combination phase, it kind of plateaued. And then in the CBT phase, it even reduced beyond that. Although, none of the patient we had on the trial liked the CBT phase, because before the trial we planned inpatient CBT, and their functional improvement was so much they did not want to be inpatient at that time. In hindsight, we should have thought about outpatient CBT, but as the research protocols are, we can't change them. We had to follow that, but it did work eventually. Now we followed these patients for 45 months, and now up to 10 years. We are in the process of wrapping out 10-year follow-up data to publish that. And as you can see, the improvement was more or less maintained. The Y-box is roughly between 15 and 10 for most of the patients at 45-month point. Life does take over at that point. When OCD becomes less difficult, there are other things, other problems which would surface. So that's why we probably see that little bump, which probably becomes more noticeable later on. Now, that was the story which was told by the clinical outcome measures. And when I was doing the trial, I was seeing changes which were profound, which we were not measuring. And I had this question that, okay, we are measuring these improvements in BDI, MADRS, Y-box. These are all validated instruments, outcome measures. But these patients are going on holiday after 15 years, taking a bus on their own, going shoe shopping. We got worried about one person who went shoe shopping and bought 6 pairs of shoes and we thought they got hypomanic. They could not go out of the room to buy shoes. They just wanted to do that. So I was like, we are not capturing this. So early on in the trial, we made this list. Okay, let's see. We called it checklist of impairments in OCD. This is similar list based on what we use in neurorehabilitation in stroke, which is a job I was doing a couple of days a week at that point. So we used the elements of that checklist of impairments after stroke, modified and applied it to OCD. And this is what we tried to do. So this radar chart, which I like to call SPLAT. So the bigger it is, the better their function is. At this level, the person is able to help someone else do the thing we are measuring. Can they help someone else with showering, phoning, housework? This is where the whole average of 6 patients started. So these are the things we were looking at. That are they able to go on holidays, manage their own finances, use the public transport, drive, laundry, things which they were not able to do. So functional improvements. And as you can see at the end of the trial, 15-month period, all patients, this orange line is the final score which we had at the end of the trial. All patients had improvement in almost all the areas, as close to normal as we can expect in any person. Now, that tells the group story. What about individual story? Now, I would like to highlight the patient number 2 there, who has the best kind of functional recovery in terms of doing things, had the least recovery in terms of Y-box. All 6 responded, all 6 achieved the outcome criteria. This is the patient who did worst comparatively. So what does it tell us? It tells us there is a dissociation between what we measure and what we see. And I think that is probably one of the reasons why clinicians should get into research, because otherwise this information would get lost. I had a question that we are not measuring that this is happening and we are not recording it. So this was an interesting kind of observation I wanted to share. Now, it is not without side effect. Any modulation in the brain is going to lead to side effects. So there are serious side effects. As I said, there is 1% risk of dying in any form of brain surgery, be it DBS. So then there are specific side effects. It could be target-specific side effects. Depending on target, we are using the most common side effect, hypomania, which we're monitoring every patient. That's why we got worried about shoe shopping. Then there are autonomic effects. There are involuntary movements that can happen. I think our cohort, probably we had few of physical side effects or immediate side effects or short-term side effects. I think most of the side effects were related to this burden of normality, which is now Amsterdam group calls it identity challenges, burden of normality. What happens when an illness you are living most of your life with disappears? You have a breakup with your partner. You have spent time with that almost every waking hour. What happens after that? So that is probably the biggest side effect we saw. And if we can go back in time and redo the trial, I'll probably say rather than CBT, we will need rehabilitation for these patients. And probably that would be the recommendation for future. But what after the trial? So since we are published in 2019, there is very it was a small 6 patients, very effective intervention, but still is small. It is not big enough for NICE to take notice, to change what it is advising, which we are trying to influence at present as well. But there has been a lot of interest in science everywhere. And there are now attempts made to cluster the data together to find what are we seeing, what is the meaning of all these things. Means we had a lot of unanswered question after our trial. Why DBS did not work similarly in all 6 patients? It worked, but not similarly. Some patients got better in seconds, some patients got better in weeks. Why? So we had no idea. Some of the patients could not tolerate some of the targets. We had no idea. So some of the cognitive effects we have seen, I'm not going to go into detail of that. That is full presentation on its own. But we did not know. So there have been attempt that has been made, and one of the interesting attempt I would like to highlight. This is by the German group, Andreas Horn's group. They have developed something called fiber filtering technique to build a model, a connectome model or OCD DBS tract in the brain. And what the finding, there have been few papers. This Ningfeng Li published the first paper in 2020. They used the data from all 6 patients as well, but they clustered this data with other centers' data to get this idea that there is a kind of OCD devious connectome, which we are still trying to fully understand. It's not fully outlined, but it connects the ventromedial prefrontal cortex. These names which are familiar to you from the earlier talks. This is nothing, none of this is surprising, but this gives us more evidence to what we are thinking, that we are on the right line. So these are our 6 patients, London group. As you can see, this is just a 3D visualization of where the electrodes are and how they are working. The 4 contacts, only one of them would be active. That would mean that it would form a area, a bubble like around it of electrical field where it would stop neural activity. So it's stimulation, but it's not stimulation, it's inhibition. We can model this. We can model this to understand what the kind of which tracts are involved, because in that bubble, if any white matter tracts or the fibers of the brain are passing, or what neurons are getting affected. So what the fiber filtering technique, which Andreas Horn has developed, their group has developed, what it has done, it has taken it one step forward. So rather than looking at targets where we were when we were doing the study, we were trying to find the best target. They've reduced the brain to these points. So they have, and these points are like 3D points in the brain where these contacts are being stimulated, where this bubble of electrical field is being formed. And they've assigned clinical outcomes. Based on the public research, they've assigned clinical outcomes to each of the point. So it's like having, we call it, like in a picture, the component of a picture on a digital screen is pixel. We can take it to voxel, volumetric pixel in MRI. This is more like neuroaxel, if I may call it, because it tells us what is happening. Is it helping OCD? It's making OCD worse. It's helping anxiety, etc. So we have this kind of granularity in the data. One of his PhD students published a paper in 2023, which is quite interesting because it threw a few surprises. They collated data from 82 patients. And what they found is not only we have sweet spots in the brain, in the tract. First, I think if we simplified, the first takeaway was that we are on the right tract and right track. Second thing is there are sweet spots, but the surprising thing, there are sour spots as well. So if we put electrode in the wrong place, we can make things worse. Third thing they told us from this paper, and this was a description of the cohort they have used, similar to what we, means kind of average of all the patients from all the centers worldwide. So they kind of divided into 2 cohorts. So first cohort was 58 patients. They used that to develop this model, which they then tested in another cohort, which was independent, different centers, which was 22 centers, to validate the model that they are kind of got the right thing. So they generated this sweet spot model, where exactly in the internal capsule we should put these electrodes, what area should be developed. And they identified 2 optimal sites. There is an anterior site and there is a posterior site, and there is a gap in between them. So now if we look at what was reported in the literature before we started doing the trials, or before this was published, people were trying both anterior, in the middle, and posterior without knowing what it is doing. So we were seeing changes, but we were no way of making sense of it. So this kind of paper has given us that knowledge, and it's quite significant. Means they have validated the model. What they have found is quite significant. There are now new trials which are being planned and already being done based on this information. So this is kind of a paradigm shift in the whole field and understanding, and does explain some of the things we observed in our trials, which we were puzzled about. Like the side effects, they found the hotspots for fear, flushing, sweating, tachycardia, hypertension, nausea, which was also reported in some of the patients. They also found that this is very close to the heart rate kind of tracts as well. So that's why tachycardia, hypertension. Now, not only they found OCD sweet spots and OCD sour spots, there were depression sweet spots and depression sour spots were found. And that, to simplify it again, that told us a different story, that we have to take comorbidities into account. When we recruited the patients, we recruited them based on OCD. So when we are selecting future patients for similar trials or interventions, we have to think at, is it OCD or OCD plus depression? If it's OCD plus depression, which part of the brain we are going to target? If it's OCD plus or anxiety, which part of the brain? So it refines our kind of understanding quite a lot, give us more precision into what we are doing. So at present, NICE does not recommend that, but we have made, I think this year is the third application that has been made to NICE to approve this. The evidence base is at present is overwhelming for DBS and OCD, and it's coming from all over the world. So the question is not whether it works or not. Question is how to support this intervention in healthcare settings. One of the sad things I see, because it's not approved by NICE, many patients are forced to go abroad, which is a risky strategy, which creates they have to come back with different practices, different hardware, different programming, which we have no idea of, we can't support in NHS. So it creates a risk, ongoing risk, and this risk is increasing every year. So this is not a problem specific to UK, it's an international problem. And recently all the researchers all over the world came together to write this crisis of access article, that here we have effective science-based, neuroscience-based treatment, which can be used in limited number of patients. If it does not work, we can remove the hardware. So it's not kind of doing something which would involve loss of tissue. However, it is not being approved. Not only in UK, and US is the similar situation. I think most of the European countries similar situation as well. In fact, surprisingly, the most use of deep brain stimulation is happening at present in China and India, and they're reporting large data sets, and they are using patients who are less severe, but still comparatively less severe to what we recruited, rather than waiting for 20 years and wasting that. Trialing SSRI for a year, trialing exposure-based CBT for a year, and then putting them on pathway to be considered for these options. That is happening as I see in the research literature. But I'm going to stop here, and so thank you very much.